organized this thing. And we're really glad to have you here. We're excited about our speaker, Jackie Dionne. She is the Director of American Indian Health and Tribal and Community Liaison for the Minnesota Department of Health. Now, I think, well, okay, where's that buried in the bureaucracy of the state? Well, she reports directly to the Commissioner of Health, who reports directly to the governor. So she's up there in the ether. She's up there with all the highfalutin folks. So we're very fortunate to have Jackie here with us today. And just a little bit about her, and she's going to talk a little bit more about her background, but this morning she was talking to us a bit, and she was talking about, she has many years in community health, working with communities in health. She, along with David Perdue, founded the American Indian Cancer Foundation. And I've seen that you're on the board of some other foundations. And so she is accomplished in that fashion and is very interested in improving the health and the well-being of American Indians, Alaska Natives, in the state of Minnesota. She's the Minnesota Department of Health, the first Indian health director in this office. And she acts as a liaison between the Department of Health and the tribes. Commissioner Ellinger established this position to work with Minnesota Department of Health to accomplish its mission of protecting, maintaining, and improving the health of all Minnesotans. And Jackie brings with her a wealth of experience working with the Twin Cities American Indian community and previously serving on several boards that have been instrumental in the Twin Cities community. And we're very grateful to Jackie because coming from Mayo, we've had the opportunity to be able to attend all of the tribal health directors meetings with the state, their quarterly meetings. And we've been given the special permission to be able to come to those meetings without asking in advance, which it makes us feel very, very unique, and we very greatly appreciate that opportunity to be able to sit and learn. And I have to tell you that Indian health and its interactions with federal government, state government, and counties is more complex than I could ever imagine. And the relationships and the issues that are discussed at these meetings are so far above my head it makes my head spin, and I don't even understand what they're talking about half the time. It is so technical. And there are a lot of issues. Every meeting, there are issues.
And we can have a conversation as opposed to me just speaking to folks. So why don't we go ahead and have you introduce yourselves?
Betty Smith, and I'm with Celebrate Dakota, a Mayo employee resource group, and then also Dakota, Chippewa, and Cree background, along with Norwegian. And so I feel very fortunate to be here today.
Thank you.
Valerie Decora Guimaras, we spoke earlier. I am a registered nurse. I'm my bachelor's, master's. I'm not working at the present time, but I'm a co-founder of the Greater Rochester Area Dakota Supporters. We network with a lot of our relatives and people on various reservations, and sometimes how to get access here to Mayo, and just some general information about American Indians in this area. We do primarily education of the community. That's what I do.
Yes.
My name's Wanda Elker-Willie, and I work in the staff library in the Plummer Building, and I'm a Celebrate Dakota member.
Hi, good afternoon. My name is Rydell Codicini, and I am from the Navajo Nation, and I am a postdoc fellow. I'm an advanced practice nurse, and I'm a fellow out of the Arizona State University College of Nursing and Healthcare Innovation, as well as the Mayo Clinic Arizona. So I'm actually here for the OHDR retreat, and I met Wes last night, and he says that I should attend this and hear what wonderful work they're doing here in Minnesota with Native people. So, thank you. And I'm sorry, my research interest is actually in hepatitis C in American Indians and Alaska Natives, and that was my work with my dissertation. So I'm actually building on that with my postdoc fellowship at the Mayo Clinic.
I'm John Tilbert. I'm a general internist here at Mayo and have had the opportunity to meet and interact with several people in Indian communities here in Minnesota and nationally, and my interests are in patient-centered care and men's health. I also play a small role in the Office of Health Disparities Research here, and always like to make it to these meetings. It's good to see you, Jake.
My name is Patty Quinsborn. I'm a nurse here at Mayo. I will be retiring soon, and we have a little resort up on in the Beach Lake Reservation area, and I don't know that I won't be going back to work, maybe, but I just thought maybe this would help me know a little bit about what's going on up there.
I'm a pulmonary physician here, and I've been very interested in how to improve health equity in general for global health, but also especially, as I understand more from the Celebrate Dakota group here, how we can improve access to care and education.
Hi, my name is Grant Morosis. I work in supply chain management for Mayo. I'm a member of the Van River Indian Reservation.
Hi, I'm Carrie Broners. I'm a research fellow, and I'm working with Alaska Native populations.
Could you speak up? I'm with the Celebrate Dakota Merge.
And, excuse me, I'm Jim Ward, also with the Celebrate Dakota Merge. My interest is basically history of the native people of Minnesota and the upper Midwest.
So that gives me a better feel for your interest and how can I better address them here today. Unfortunately, I'm probably not going to hit on everybody's interest today, but I am open to trying to answer any of your questions. Today what I'm going to do is talk a little bit about who I am and how I got to be in the position that I am today and why it's so important to have these positions at state level agencies. And then I'm going to talk a little bit about some of the demographics of the American Indian population here in Minnesota. And then I want to open it up to conversations, but if you have a question at any point in time, please just raise your hand and ask. I do much better having a conversation with people than I do just talking up here, because I can go on and you guys are just kind of go, okay, when is she going to stop? So just ask a question and I'll be happy to answer it, and if I can't, hopefully maybe there's some expertise in the room that can. So let's have a conversation today. Bonjour. I'm from the Turtle Mountain Chippewa tribe. My name is Jacqueline Dionne. I do not speak Ojibwe. The language that's spoken on my reservation is called the Michif language. It's a combination of French, Korean, and Ojibwe. It is an Ojibwe band that went up into Canada during the treaty times to get away from the wars that were happening, and then the Turtle Mountain band under Little Shell was brought back down to the United States. And that history is little is known about that. It's a small tribe in the middle of North Dakota, 10 miles from Canada. My parents grew up there. Both my parents are enrolled members, and I am an enrolled member of the Turtle Mountain Chippewa tribe. I did not grow up on the Turtle Mountain Reservation. I grew up in Minneapolis. My parents relocated in the early 70s under the BIA relocation program, And so we were one of the first families in a predominantly white neighborhood of northeast Minneapolis, which was Polish area at the time, and pretty ingrained in that. And I graduated in 1982 from Edison High School. So I would be considered first generation urban American Indian as opposed to being raised on a reservation. And I wanted to point that out because a lot of times you'll see American Indian folks in all walks of life, and you know, the assumptions can be pretty rampant in terms of who we are as people, but we run a variety of different backgrounds as much as anybody else. And a reservation experience is much different than an urban experience. And my experience is coming mostly from being raised as an American Indian person in an urban environment. Although a lot of the way we were raised was based on my parents having been raised on the reservation. So I'll touch on that a little bit as I go along. So that's who I am and where I come from. Like I said, I don't speak the Ojibwe language, otherwise I would introduce myself in Ojibwe, which is customary, but I know this much. And so, graduating from high school in a predominantly white environment, I went on to the University of Minnesota, but not right away. I had a few years of hard times and some challenges with the academic system. It took me 10 years to get my bachelor's degree. I started in 1982, but I didn't actually receive a bachelor's degree till 1993. And in that time, I also had a daughter. I have one child, and she's 25. And she recently blessed me with my first grandchild, a grandson. He's 2 months old, so now I have my boy. I graduated in 1993 from the University of Minnesota with an undergrad degree in early childhood development. And at the time that I was working in the community, I started off in high school working in Native nonprofits, American Indian nonprofits in the urban area, and graduated and went back to work in the community in early childhood development. I really was interested in learning what are the core causes, or what can we do to really change the way we are as a community? Because at the time when I was growing up and my life experience was a lot around alcoholism and domestic violence and abuse from the demise of that reservation life. And back when my parents were growing up on the reservation, Turtle Mountain was pretty bad. In the last 30 years, it's turned itself around, and it's a much different community than when they were there. But again, I was just, why do we have such poor health? Why are we considered to be, you know, drunks, and that whole stereotype of who an American Indian person was? So my thought was to work with babies and to really try to work with moms and babies to turn around that trajectory of outcomes for us as an American Indian person. So I started out in early childhood, and plus I had my daughter. She was, she was newborn, and I wanted to learn more about her development and be the best mom that I could be. And so then I graduated in '93 in early childhood. But then I spent the next 15 years doing human services and social services in the urban community. Did 7 years of early childhood work, and then in 2005, I was hired at Department of Human Services to do aging and adult services for older American Indians. Out of all the populations and even subpopulations within the American Indian community, our elder population is the worst off of any population in the country. And so, you know, not that I had a background in working with older adults. I started out working with babies, but I ended up in 2005 working in older adults. And it was a program, it was providing long-term care services and state services to reservations and developing those programs with each community. But then we also had a program at the state called Wisdom Steps, Preventative Health for American Indian Elders. And the idea with that program was to get elders active in the community, staying vibrant so that they don't go back, they don't end up in the nursing home and live the rest of their lives off reservation. And we wanted to keep the elders in the community because that's the transfer of knowledge, culture, and traditions. It's still around. It's around for 14 years. I didn't start it. I was kind of the middle person in Wisdom Steps. And then the commissioner, the current commissioner of health at Ellinger, had been working with some of our tribal leaders and some folks within the Minnesota Department of Health. And they convinced him, and he was already in this realm of knowing the importance of working with tribes, that they really needed a position at the executive level to work in government-to-government relationships with tribes There's 11 nations in Minnesota, and they're all distinct of each other, and so having somebody on staff to advise him that knows the nuances of all 11 made sense. So then he put this position together. They put it out for people to apply. I applied. If I got it, great. If I didn't, you know, I was happy doing what I was doing, working in the older adult population, and sure enough, it was offered to me in May of 2012, and I've been there ever since. You know, part of my thinking that I wasn't going to get the position had to do with me not having a degree in public health. I'm like, well, other people I'm sure will apply who have higher level degrees than I do. I do not have an upper level degree outside of my bachelor's degree, but I bring a wealth of experience working with the American Indian urban community and some with the tribes. And I think that having this position now there at the health department for 2.5 years has really brought some insight into what we've been doing at the health department as far as reaching into the American Indian population, both urban and on the reservation. So that's a little bit about how I got here to where I am today. My work really involves getting to know folks at the local level and having those relationships. Like I said, there's 11 tribes in Minnesota, 7 Ojibwe tribes in the northern part of the state, and 4 Dakota tribes in the southern part down here in this area. The total population throughout the state is 101,000. And the reason that number is of 2 figures in the census. The folks that said they were American Indian only, and folks that said they were American Indian and at least one other race. That's the combination of those 2 numbers. And the reason why I put those together is because if a person is going to identify themselves as American Indian first, chances are they are going to be utilizing services and identifying themselves in other demographics as American Indian. We have quite an array of folks with mixed backgrounds, especially in the urban area. We'll have children that are born American Indian mom and Hispanic dad, American Indian mom, African American dad, and vice versa. But if they say they're American Indian one for their first identification, that to me tells me that they are raised within that American Indian home, knowing who they are as an American Indian person. So that's why I say there's 101,000 American Indians in the state of Minnesota. Yes?
How many would you estimate are undeclared?
You know, a lot of folks don't fill out the census, so that's under probably reported. Those are folks that actually fill out that census form. We have a lot of folks that don't, so we're always underreported in the census, no matter how much they try to outreach to us. I don't know that it's that much higher. We make up about 2% of the population in Minnesota. There's 5 million people in Minnesota. And the reason I bring that up is because the Minnesota Department of Health, as opposed to Department of Human Services, the Minnesota Department of Health is around improving populations, getting communities to become healthier by doing activities within communities for the whole population. A lot of the environmental health work we do too, and a lot of work we do around the public health lab, keeping people healthy. You know, we test all kinds of stuff at the Minnesota Department of Health. But, you know, nobody knows the extent of everything that we do because it's always behind the scenes. And if there's not an outbreak of a disease, the Minnesota Department of Health is just doing their job. And I didn't know the breadth of everything within the Minnesota Department of Health as I do today to understand all the work. But again, the conversations at the Minnesota Department of Health is going upstream and getting at the root causes of why we have certain diseases or health status. Where human services is about people accessing assistance after the fact. So there's always a need for assistance, and then human services is there to provide that payment source for mental health counseling, for chemical dependency counseling, for medical assistance, as a person needs it, not necessarily getting into a community-based approach to keeping people from getting sick. I passed out that health disparities of American Indians as well. It has some health disparities, but it also talks about the social determinants of health. And the Minnesota Department of Health will speak on and talk to folks about the conditions of which create health. When you have people in impoverished conditions, their health is not so good. When you have people in optimally thriving communities, their health is better. We know that income, the higher a person's income is, the more likely they are to be healthier, because they have access and they can pay for certain things that people that are poor can't afford. We know that when people are gainfully employed, they're more likely to be healthier, because they have income and they have access to insurance. When there's housing, we know that people that have good housing are more likely to be healthy. People that struggle with housing, that are homeless and don't have access to good housing and live in inner city, dumps that people just rent to anybody, they're not likely to be as healthy. So those social determinants, the conditions of which people live, work, and play, is a huge determinant on how healthy we are. And then the other one is personal behaviors, and the personal behaviors. And within human services and a lot within some of our health department, we tend to talk a lot about changing the individual, providing opportunities of which people can eat healthier, exercise, make choices that are healthy because they have a grocery store close by. And that makes up a part of who we are and how healthy we are. But that's only, so the social determinants and individual behaviors make up about 70% of how healthy we are. I think it's like a 60-40 split, where 60% is social determinants and 40 is around individual behaviors. Only about 10% of how healthy we are is our healthcare system. Going to the doctor, getting checked for this, getting checked for that. If we only rely on healthcare to determine how healthy we are, we'll only get to 10% of being a healthier community. So the commissioner and folks within the health department really talk about these social determinants, the conditions of which we live, work, and play, and then the health in all policies approach. American Indian high schoolers have the highest dropout rate in the state of Minnesota. We only graduate around 40-some% of our American Indian students from the public school system. And it's one of the worst in the country, Minnesota is. And yet we have one of the best educational systems in the country. So there's just this disconnect in how we're working within our population, not just American Indians, but all populations, to have the access to quality education as everybody else. And it's not there here in Minnesota. So there's the inequities, and the health department recently established the Office of Health Equity, of which to address some of those conditions of which people are live, work, and play. And my work is aligned with the Office of Health Equity, but it really is focused in on the American Indian population and those 101,000 individuals. Go ahead.
How is that 101,000 split between reservation and off-reservation? I'm wondering if, too, that the off-reservation, is that only counted in the 7-county metro area or all state big cities like St.
Could you
Cloud,
repeat the
Mayo?
question?
Yeah, so the question was, how does the 101,000 split out throughout the state of Minnesota? It's about a 30% on reservation, about 30% in the surrounding counties around the reservation boundaries, and then about 30% in the urban area. So
When you say the urban area, though, that's what.
that's the 7-county metro area.
Right, so,
Yeah.
but you're counting off reservation as well as like St. Cloud, Mankato, other.
Yeah, 30% surrounding area. St. Cloud, Mankato would be the surrounding area. I don't know that I would say that that was the urban, because in the Hennepin County and Ramsey County statistics, there's like 12,000 some hundred in Hennepin County and 9,000 in Ramsey. So that makes up about 30-some thousand.
And I'm just wondering if Indians in Mankato and St. Cloud are missed in your stats.
They might have not been as counted if there wasn't a good outreach, and the population is small in those areas, and so I don't know. We can break it out by county and by city, the American Indian population by that, but it's small. It's not a large population like some of the border towns on the reservations. Bemidji has one of the largest American Indian off-reservation communities.
Even like Duluth, how would Duluth be going?
Duluth would be, it would be on, surrounding the reservation, and it's considered urban. And you can look at the census and just find Duluth's American Indian population. It's big, but it's not as big as Bemidji. I'd have to look at those. And I wanted to offer, and I offered to Wes, to come back another time. Today was a presentation of this position and what the health department has been doing with the tribes. But I have an hour-and-a-half presentation where I talk about federal Indian policy historically the last 500 years, and then its impact on the health status we see today. It's an hour-and-a-half presentation, and you can't cut it back at all because then you're rushing to get all the information out. But I bring more demographics to people at that point. And you definitely can look at the census information, and our state demographer sends me that information all the time. So I can get those, but it's small. It's, you know, it's 5,000 to 10,000 people at the most, compared to how many millions here in Rochester, you know. So we're a really small population in any area of the state. Which doesn't mean we're insignificant. That's the other thing that I was going to point out. And when I talk about that federal Indian policy, what I do is I talk about how it came to be, what happened to us in terms of the ceded land that came to Minnesota, what went to the federal government and then to the state as when it became a statehood, that the hundreds and thousands and millions of acres that we said we would not hunt and fish and gather in anymore, we did that to survive. And by doing that, we were promised certain things to guarantee our survival. Those promises weren't held. And yet everybody in this room has that obligation because you're here in Minnesota and you're a Minnesotan because of what the Indian people in the state had to give up. And we're not insignificant. And so even though we're small in numbers, we still have a significance in the state, and we have the right to equal health as everybody else, to be just as healthy as everybody else. But there are conditions of which having that happen and how we get there is not for us to determine. Well, it's for me to determine for Jackie and Jackie's family, but it's working with the community, and it's working at the local level for what folks say they need in order to then move to become healthier. And I want to take some examples like the Mille Lacs Band of Ojibwe, the Shakopee tribe, Prairie Island, some of our Dakota. The Dakota communities are some of the smallest communities in the state. Lower Sioux, 700 members, Upper Sioux around 400 members, Shakopee around 500 members, and then Prairie Island's probably got the largest, up to about 900 members. They're very small communities. Gaming, since the mid-1980s, has brought in general revenue fund into those communities, so people are no longer living in poverty. Prior to gaming, they did live in poverty, and they were on a lot of the state-run programs just like everybody else, but today they are not. The conditions of which people live, work, and play in those 4 communities, as well as Mille Lacs and somewhat with Fond du Lac, have changed since the mid-1980s, but the health status across the board has not changed significantly for us. And so there's some work that needs to be done within partnerships so that, and of course 30 years is not going to be a big amount of time to change 500 years of oppression and what had happened to us as American Indians for us to change our health status. But we have to be in partnership with the tribes to really figure out what is needed in order to improve the conditions of which people have a healthier outcome. Diabetes is one of the worst in the country and one of the worst in the state. And there's a whole history behind the Commodities Food Program and how we were not allowed to hunt, fish, and gather that brought us to where we are today with diabetes. But we have folks that grow up on reservations and in urban areas who will say, as a young 20-some-year-old, not if I get diabetes, but when I get diabetes. So it's like this foregone conclusion within our community. And how do you change that trajectory that, no, diabetes does not have to be your destiny. Heart disease does not have to be your destiny. And so how can we change those conditions and the norms of which people transfer traditions and culture down to the next generation, so that we can have a future generation that's healthier than my generation, than my mom's generation. And we can do it. We can do it. Go ahead.
How do you, and I don't know if any collaboration is going on now, but how do you, if you could write the ticket on how Mayo Clinic works with your office, what would that ticket say?
Well, I'm not sure that it's working with the health department with the tribes. I think it's how we work with the tribes collectively.
Okay.
You know, the health department, the clinic system, the hospital systems, the tribes. How do we work as a partner together? And I don't know what that looks like, and I don't know that answer. And part of it is because the tribes have to decide that on their behalf, and how we want to go in there to work with them. And so I do think that they are having these conversations around the state on what they would like us to do as partners. But again, too, the population of which they're representing, these elected officials, and when I say the tribe, I'm talking about the elected officials. I don't talk about individuals within the tribe. They're huge decision makers, our traditional people, our medicine people, our elders. They're the behind the scenes. They really are some of the decision makers. But when we talk about working in partnership with tribes, we're talking about tribal elected officials, because that's the relationship we have on the government to government relationship. And these elected officials have so much on their plate, running multi-million-dollar businesses and trying to figure out what to do with their constituents. It's a crisis a day to try to put out. And when it's a crisis a day to try to put out because of the lives and the conditions in which people live, it's hard for them to sit down and actually think about ways in which they want to work better with folks like Mayo. And they want to. It's not that the door's closed, it's just it takes the time for the health department, the Mayo Clinic, the health systems to be in spaces with folks to develop those relationships. And when they're ready, you're there. And so it's hard, especially when, you know, we want these outcomes and we want to do this grant and we want to get this impact. And it's hard because the tribes are not there. And we really need to be where they're at. So that's the partnership that needs to be developed. And hopefully this position, because of some of the relationships that have been massaged and worked with and stuff, and it's not just that it's Jackie, but it's that this position is there, and that no matter what commissioner comes into the health department, they see the value of the relationship building, and this position will always be a health department. The consistency of that position is what's going to really massage that relationship, and hopefully get to that point where then they are saying to us, any tribe, here's how we want you to work with us, and here's what we got as far as being able to work with us. But when you're dealing with a crisis a day, it's really hard.
Thank you for offering hope.
Yeah.
One population that I think might be a good one for us to focus on, although all the groups need them, is the Native American veterans.
Yeah.
If we have veterans from each of the tribes, and we can create a electronic epidemiology sort of architecture of the Indian Health Service database, the private EMR, and the Department of Defense, the VA system. When those patients come out of network to Mayo, for example, I think it would be a wonderful opportunity to figure out how do the systems talk to each other, and then how do we actually intervene in a way that's helpful to the individual, but also to transforming the systems.
Yeah, yeah.
Do you have thoughts on how to connect MDH with Native American veterans and health as a subgroup of this massive?
No, but it's definitely doable. I mean, the health department has health information technology, exchange, health, HIE, and it's a huge thing that they're going around connecting partners to providers to providers. And you definitely could take the veterans as a subgroup and figure out how to get the provider that's doing home care to talk to the doctor, to talk to the nutrition program, and to get transportation services for that veteran. And it's doable. I think that the challenge is, and this is again, you know, we're a small number, and so unless we're really knocking on that door, people aren't giving us large amounts of money to do infrastructure for technology exchange. And so that's a huge challenge, I think, with tribes, is just getting their own technology up to par to speak to a hospital system's technology. It's still a long ways away, and a lot of it has to do with the lack of resources. And even though gaming has brought millions and millions of dollars to the local level as far as general revenue, we're still talking about tribes that have plumbing issues to get water out to people's homes, and building schools and building roads and getting housing. Those dollars right now are still going into infrastructure for a lot of our tribes. Some tribes have built up their infrastructure, and they're pretty much ready to put those dollars now into these kinds of efforts for better care.
I wonder, what kinds of collaborations do you have going on with youth? I mean, I can see a real potential there when we have our graduation rate, so they're not any better when I graduated, they're still pretty bad. So I'm just wondering if there's, it just seems like that's a real, I mean, if there could be something done there to help these youth, to help health, I mean, there's just seems like.
Yeah, you know, and part of what is a challenge, and my work at the health department has involved bringing all 11 tribes together under a symposium to just for them and for the tribes to decide what is their priorities in terms of activities. We give dollars out for eliminating health disparities, what they're called EHDI. It's a small amount of money from the state legislature for changing the disparities, and many of the tribes put those dollars towards youth activities and helping youth develop better behaviors. But it's got to be more than just one pot of dollars. It's not just our dollars that are going to make that change. The tribes have to put that in conjunction with other pots of money that they have for youth development and youth work. Every tribe is definitely having services and programs for their kids. How do we complement their efforts with the dollars that we do have? We, put grants out and opportunities for tribes to apply to grants, and even in some respects, we put dollars specifically just for the American Indian communities. They can choose to do what they want with those dollars to whichever efforts. Teen pregnancy prevention is one of the areas we do, eliminating health disparities, and then home visiting to moms with young babies are some of those things. But those dollars don't fund a program by themselves. They have to go into other dollars from human services, from the federal government. The tribes put them together to develop a program. Every tribe has their own youth development programs across the state, and how we complement those. We did have the state legislature in the last session, or 2 sessions ago, put $35 million into the state health improvement program they call SHIP, and you'll hear that across different counties and local public health. We put $1 million for the tribes under SHIP. $1 million for 11 tribes is not going to go a long way, but it's an amount just for them. That they're not in competition with counties for that million. So they get a pot of that money to do their SHIP activities around increasing physical activity, increasing nutrition, and reducing obesity and tobacco use. So hopefully we can help them develop a program that will make those efforts and complement it with IHS funds or with some other funds to help support general funds to help support those efforts. Any other questions?
What's your dream? And where do you see us being the most effective or impactful if we work together?
Yeah, so my hope in this position, and again, I'm at the whim of the commissioner, so, here today, gone tomorrow. But if I was to end up staying at the health department until I retire for 17 years, I would love to see the health status and the change in our health outcomes be almost as good as white, if not better. And we can be in 17 years. I don't know if that can happen, but we could get a good start on it and really see that turning around and closing that gap. Racism, structural racism has a lot to do with that gap. And once we can challenge those and who's making decisions on our behalf on what system, that can have a huge impact. Tribes like Shakopee, because of the resources they have said, we're not going to even deal with your systems anymore. We're going to just develop our own systems, serve our own people with our own resources, and good for them. But again, too, they're challenged with turning around the health status of their members, and they have not gotten there yet either, even though they have an abundance of resources at this point. It takes a community, and how do you develop a community to want to be healthier? And that's the hard work that goes in with doing population health, that it just doesn't have one person. We have a really good system now that wasn't here 30 years ago in getting access to services. Now we do. An individual can get mental health services, an individual can get chemical dependency services, and if they qualify for state programs, they can get the state to pay for those programs, or they can get the tribe to pay for them. Individuals, we have a really good system, better system, for individuals to get help. We don't have a really good way of improving population health and changing how domestic violence and prescription drug abuse does not have to be who we are. And yet it's hard to change that in a community that is accepting of that behavior and saying, oh, that's just the way it is. How do you change that kind of community conversation around that we don't, that, you know, the opiate explosion in the state is terrible for everybody, but it is even worse for us. And it's worse for us because of the fact that we have a population of which addiction is such a commonplace. And the addiction stems from these childhood experiences of the individual growing up. And so when you have that happen, you know, heroin and prescription drugs is just going to take off because people want to escape the pain that they have from the trauma they experienced as children, even though they'll tell you, you know, my childhood doesn't affect me as an adult. It does. And so how do we get that to change so that not necessarily, I mean, if the individual wants to get help, they have the opportunity to go get help for their addiction, but how do we change it so that trauma isn't transferred to the next generation of children in that family? And that's the community work. That's us saying we're not going to deal with this anymore. We haven't quite gotten there yet because of the rapid acceptance of, I want to say addictive behavior, but not necessarily addictive behavior, of just thinking that that's the way it is for us. You know, everybody uses, so I'm not going to be exception to the rule. You know, and if you are the exception to the rule, sometimes you're seen as the outcast of that community. And so, you know, we have a lot of shaking hands, and it's still there today. Even in some communities like Shakopee, where there's just a lot of resources to change. And yet there's still these issues of, if I do it differently, if I choose this other path and not this addiction path, then I'm seen as being better than them. And we still need to change that in the community.
Sorry, can I ask something? Sorry. I went to Dr. Dionne Warren's presentation in Oxford College this spring, and I was so inspired by filling that gap of public health with individual health. He actually is really intending on developing people with masters in public health and then inserting them back into the tribe. So do you have any collaborations in mind where some of his graduating students come in over the next couple of years?
Yeah, so the question was about Dr. Dionne Warren, who's the director of the Masters of Public Health at the North Dakota State University, NDSU, and he's developing a fabulous program to train American Indian folks with Masters in Public Health and then putting them back out into the different tribes in the urban areas. And in fact, we are in partnership with his team and developing what we're going to call the second Minnesota Indian Health Symposium. The second Minnesota Indian Health Symposium is going to build off of our first one, of which we brought tribal elected leaders and tribal health directors and decision makers. We didn't do an invite to anybody to just register, but we put those folks in the room. We had a really good dialogue on the first symposium of the issues, and we have those documented now down on paper, what people in the room said, not what the health department says is your problems, because we have that documented all over the place, but what did they say? And then the second symposium, his team is coming on with us at the health department to facilitate and put together another day and a half of conversation and hopefully coming up with some sort of start of an action plan. And what are these tribal elected leaders, tribal health directors, and key decision makers within the tribe, what are they saying is an actionable item that they can do in partnership with us to improve health? and then work on some sort of an action plan for the whole state of Minnesota to improve the health status of all American Indians in the state of Minnesota, not just in one specific tribe. So I'm excited about that one. Yeah, no, he's coming on board with us at the health department in this vision of becoming healthier as a population. And wouldn't it be amazing if Minnesota could turn around in the next 20 years and become the healthiest state for American Indians in the country, rather than one of the unhealthiest states for American Indians in the country? How do we do that in partnership with each other?
And with that symposium, are you including elders in on that too?
Yep.
Because I would see Emmett Eastman as somebody so valuable.
Yeah, so the invite goes out to elected leaders and tribal health directors, and then they choose who to bring in with them. We don't designate individuals on behalf of any one community. And I intentionally do that because I don't want to be told, well, who said that they were representing me? You know, I leave it up to each community to decide who they want to send to the symposium. But it is an invite. You have to receive the letter from the host tribe to come to this symposium. And I know a lot of people want to be in that room, and a lot of people want to hear that dialogue. But then the intent is to take these action plans, once we have an outline of it, not necessarily the nitty-gritties of it, but then to have each team from each community that had come to the symposium take it back and get input from their constituents and from their members to their action plan. And so there's going to be a whole year of a process of getting input into an action plan that hopefully will have a 10-year strategic plan kind of thing. I call it an action plan because people don't like that word strategic plan. They tend to get lost in what does that mean. But, go ahead.
If that consortium is host tribe centric, who's representing the urban Indian members, tribal members?
Yep. So each urban group, and I know you're going to ask me about the Duluth, St. Cloud area and Rochester. But in Minneapolis, there's a group called MUD, Metropolitan Urban Indian Directors, of which the invite would go to that group for them to determine then who would come to the symposium on their behalf. St. Paul has St. Paul Indians in Action, of which is a conglomerate of nonprofit organizations. They would decide then who would come on their behalf. You know, Duluth has a nonprofit up there that works pretty strongly with the community, and Fond du Lac also has quite a few folks. But it would be Minneapolis, St. Paul, Duluth, and Bemidji. I don't know that I would include St. Cloud or Rochester, because I don't know that there's an organized.
I'm just concerned that the urban Indian
Sorry.
population is underrepresented if it's tribal centric.
Yeah, and in the first symposium, you could say that it was underrepresented.
You know, because they're representing 30% of what you said, and
Yeah.
there's 70% more Indians.
Yeah, and I'm going to connect with these ladies down here to see about Rochester's area.
And I think your comment about small but not insignificant
Yes.
is really important.
Yes, yeah. No, I agree. And it's really a challenge to think about how to be representative of the whole state. It really is. But the tribes just really have a big pull in that government-to-government relationship, because it is a government to a government. Urban areas tend to have less of that government to, you know, just not as distinct nationwide, as a nation. But they're not represented, and I'll reach into folks that I need to reach into to come to the symposium. Because it is important. If it's an action plan for the whole state of Minnesota, I want folks to see themselves in that action plan as best as we can. We're not going to catch everybody, and I just know that. The Advancing Health Equity Report, of which went through the same kind of process, and there will be folks that will say, we wrote 10 pages, and I don't see any of it in the report. It's just hard to capture everybody's input into an advancing health equity that is so extensive as it is. But hopefully people see some of themselves in the report. That's
Jackie, something else that we're working on here is, maybe it's kind of in parallel to your symposium, but we're trying to get to the point of holding a conference here at Mayo with each of the Minnesota tribes, to talk about their priorities. It'd be a conversation between tribal health leaders and Mayo clinicians, investigators, priorities to tribes through research.
Yeah.
And, where can we respond? Sometimes research is pretty pragmatic and very practical, and it can be low-hanging fruit, and maybe that's a place where we can start. But we're trying to work toward a meeting like that, hopefully now by maybe the fall of next year.
Sure.
And one of our issues right now is simply having sufficient funding to address the number of people who are interested in coming. And we're going around and visiting each of the tribes first to talk to them about that.
And so Wes was asking about the research and partnering with at the first symposium, one of the things that did come up as far as the conversation was the data and the lack of good data about what's happening in each community as well as across the state. And so I anticipate one of the action items out of a statewide plan on improving the health is going to be around research, appropriate research, who does the research, how do folks work with the communities to get the research done, and who owns that research. That's the biggest conversation right now with the tribes, is the fact that if you come on our reservation, we want you to do this best on our behalf. We want to have a benefit back to that. We want to use this research and we want to own it. It is our research. And so how does a place like the health department, who's got public information and the access to information law, that we can't hold data in seclusion, that we have to have the tribes own it? How does a state agency work with that kind of situation to do research? And we're probably not the best ones to do that. And so how do we figure that out in terms of working with the tribes around that? So I think it's all part of that big picture of improving the health, and research is a huge component of what we're doing as far as data. Data drives funding drives change, and the reality is that tribes need money. They need money for change. You can't have housing without paying a contractor to build a home. They need money, and so how do we give them the tools in order to secure the funding, in order for them to improve the conditions of which people are living on the reservation, and in our urban areas too. Part of the challenge is that once you leave the reservation, you are no longer getting the services from that reservation unless you go back. But we have to be able to provide equity to all American Indians, no matter where they live, on or off a reservation. So we got 2 more minutes, and I'm so sorry. If you have more questions, I'd be happy to stay for a little while.
Well, let me ask a question of the group. Would you all be willing and able to stay for an hour-and-a-half presentation by Jackie?
I would.
It's on the federal Indian policy, and so I touched a little bit about it, and it answers a lot more of the questions you have about what the impact of federal Indian policy is huge, and we're the only population that has the impact of a federal policy directly to eliminate us as a people. And when you have policies that directly want to get rid of you, how does that make you feel? It doesn't make you feel very good. But then when you see the tribes asserting themselves and wanting to declare their own destiny, then you see clearly why that is in this presentation that I give. So I'd be happy to come back.
There are a lot of lessons that we're learning right now in having intergovernmental conversations with the Ebola outbreak.
Yeah.
And there's a high-level discussion that went on with WHO on the research and the ethics of withholding services that are really beneficial. It might be a timely conversation to have when we talk about health and disparities research.
Yeah, yeah.
And, I'd be happy to share more as I learn too.
Yeah, Indian Health Service, try as they might, they're only going to do so much because they're underfunded.
Right.
They just don't have the funding that's needed to provide for the level of care that's needed in Indian country. The federal government in the treaty said, yes, we will provide for your health care and take care of your ill and your sick, but that doesn't mean it has to be good care. There was no guarantees in treaties that it had to be good quality care. And so IHS has struggled over the years to provide that care for us, and that's just an inequity that's wrong. IHS needs to be funded at the full level of care that's needed for American Indians, both on and off the reservation.
Because the Affordable Care Act.
It has.
Correct.
Yep. So I want to say that there has been a a change in federal policy around the Affordable Care Act, and the Indian Healthcare Improvement Act is part of that. It allows for Congress to give more money to IHS. So there's hopefully a change along the way. Thank you.